Good evening, everyone. Welcome to the Florey. I am Eloise Holmes, and I look after our donors and philanthropists here at the Florey. You may or may not know it, but the Florey is a not-for-profit organization, and it is a registered charity. So any gift to us over $2 makes a big difference in the breadth and scope of our work here in brain research. For example, some of you had a chance to have a little bit of a play and a little bit of a look at the stroke ambulance that is parked outside, and that Wheels in Wonder is an outcome and a result of philanthropic gift to us. So if you want to talk about supporting the Florey, do feel free to catch me after the presentations tonight. But tonight we have a powerhouse combination of experts presenting on the latest in stroke and how Australia stacks up against the rest of the world. I'd like to call these two the rock stars in stroke. I used to work at the Arts Centre, and I'm finding a lot of analogies between medical research and the performing arts. But Professor Geoffrey Donnan and Professor Stephen Davis have worked together for a long time, and one of their joint passions is that stroke ambulance that you saw outside. Jeff, of course, is the director of the Florey. He is a world-renowned stroke expert, renowned for his stroke research. He has been on the world stage for many years, and he has established the World Neurology Foundation, as well as the World Stroke Foundation. He has led the Florey in the past decade during a period of remarkable growth and progress. Professor Stephen Davis is Professor of Translational Neuroscience at the University of Melbourne, and he is the Director of the Melbourne Brain Centre and Neurology at the Royal Melbourne Hospital. He is immediate past president of the World Stroke Organisation, and he leads a large clinical stroke research group at the Royal Melbourne Hospital, University of Melbourne, working in close collaboration with Jeff. Jeff will present first, followed by Steve, and then you can ask both of them questions at the end. If I can ask you please to turn off your mobile phones or put them on silent, and welcome Professor Geoff Donnan.
Well, thanks, Eloise. I must say I've been called a lot of things, but never a rock star. So that is a first, Steve. I'm sure the same for you. I'm often asked, why do you do this? And there are a myriad of reasons why I do this, but I just want to draw out something. I got a bit of a surprise tonight. A person came up to me and they said, "I look a bit familiar." And he said, "I look a bit familiar." He said, "I was treated by you 40 years ago at the Austin Hospital Stroke Unit." I'm not going to identify you, but I must say I was chuffed. And he looked even better than me, so not bad, good outcome. So we're going to talk, and what we're going to talk about is I'm going to give you a map of what we're going to do. Firstly, a lot of you won't even know what stroke is, so I'm going to give you a little stroke lecture on what Stroke 101. Then I'm going to talk about the latest treatment, which is really removing a clot, and it is spectacularly successful. I also want to bring in the idea of telemedicine, which we've been rolling out through the Florey, Victoria-wide. And then Steve is going to talk about the stroke ambulance, which many of you have seen is just outside, and as Eloise said, is one of the most exciting things that Steve and I have ever done. So Stroke 101, let's get down to the facts. It's the second most common cause of death. In Asia, almost universally, it's the first cause of death, number one cause of death in Asia, mainly because blood pressure is much higher there. In Australia, there are about 60,000 strokes every year, about 160 per day, 6 or 7 per hour, one every 8 or 10 minutes. So unfortunately, while we're here, there are going to be quite a few strokes that are occurring during this hour or so. Very unfortunate. A basic principle is that 80% of them are due to a blockage of a blood vessel, so-called ischemic stroke. 20% are due to a burst blood vessel, and often secondary to high blood pressure. And it costs us about $3 to $5 billion per year. Now, there's another key principle you must understand. Once the stroke has occurred, we use the word time is brain. Every single second counts. You haven't got a second to lose because there's a steep curve of lack of effect every minute that goes past. So we need to act quickly. So we use the phrase time is brain. It's been calculated that you lose about 2 million neurons per minute after the stroke onset. So you can imagine we don't sit around saying, what do we do next? We've got to have things down like a military operation. We work fast. This is what it looks like. And this was one of the most amazing things when Steve and I trained in neurology. We started training together. We were in medical school together. In 1977, we got our first scan in Melbourne, CAT scan. And these are the sorts of things we saw for the first time in walking, living people, which you'd never been able to see for what people have been on in Homo sapiens for 300,000 years. First time ever. So it was extraordinary. We're able to see an ischemic stroke, so the CAT scan goes very dark in that area, not immediately, often it takes quite a few hours for that to occur. If there's a bleed, instantaneously you see this white blob. And we know now, particularly work that Steve has been doing, that the white blob naturally starts very small and just goes kaboom over a period of hours or minutes. So these are some of the mechanisms we need to understand if we're going to treat these people with strokes of these two main types. Now, over those years since 1977, when we could do no investigations, almost none, we've had all these introduction of these various imaging capabilities that enable us to work out in most people what has caused the stroke. So we can do a CAT scan, an MRI scan, an ultrasound of the artery here. This is the heart and this is the brain, a cross-section of the brain, and these are small vessels, big blood vessels here in the brain. And you can see that there's a main highway between the heart and the brain, which is good and yet it's bad, because clots can go from here up to here, stop when the blood vessel gets too small and cause an occlusion. And of course we can do ultrasound to see where the clot's coming from in the heart. So this enables us to subclassify the patients with blockages into either the small vessel blockages, large vessel blockages, or from the heart. And about 25%, we do all these investigations and we still don't know what's caused it. Further research required, as they say. Now, when Steve and I were starting off our training in 1977, we drew up a list and said, well, let's draw a list of the proven interventions for stroke, because we were both going into stroke, and say, well, what have we got so far? We drew up the list and it looked like this. 0. There were 0, 0, 0 interventions as recently as 1977 for acute stroke. Now, this is just to improve outcomes after the stroke has occurred. 1, 2, 3, 4, 5, 6, and there are about another half dozen to prevent stroke, about another half dozen to prevent another stroke after you've had the first stroke. So the progress that is being made is just going up like that. It is far beyond what we'd ever expected would happen. So management in a stroke unit, this NNT1 just means how powerful is the intervention. That's not all that powerful, but good. This not so powerful, not very powerful, but these are starting to get very, very powerful. And you'll come down to this one and we'll talk about, which is clot retrieval or thrombectomy it's called. What that means, for every 3 people you treat, 1 person will benefit. It's almost getting as good as 1-to-1. It is an extremely powerful intervention. We're going to talk about that. So let's see what all this means. So for years and years and years, we knew that 80% of them were due to these clots that were sitting up there, and it was the most distressing thing when you'd go down to the emergency room, someone would be there, they couldn't speak, they had dense weakness down one side, and you knew exactly where that clot was. And if only you could drag it out, that person would get up and walk home instead of a life of severe disability. Very frustrating. So for years and years, we've been trying to work out how this might occur. So finally, people have been fiddling around with these things. There was the so-called Mercy device, which gained a lot of publicity because it looked like a wine corkscrew, very appealing. Imagine you could be having dinner and you could do something. So it screwed through the clot. This is an artery in the brain. It screwed through the clot out the other side, and then you dragged it back. And there was a big trial that went on called MR Rescue. A lot of these trials have got these funny acronyms. Published in the top journal in the world in 2013, negative. And we've been through so many of these trials, and we thought, oh, again, we failed again. And believe me, research is like that. You fail 20 times and you get one win. So you've got to live with failure. But you press on. And two things led us to, I suppose, keep going and keep trying. One was that was now the ability to do an image with the MR or CT to show that whether the brain was still living or not. And this is from an MR scan. This is just colour-coded to show this bit of brain is dead. This is a couple of hours after the onset of stroke. But this bit of brain is still living. So that tells us that we call this a mismatch. There's a small bit versus a large bit of 43 mil. There's a big mismatch of still living tissue. So it's worth pursuing and trying to unblock the blood vessel. So that was a huge breakthrough. We were able to use this to assess whether therapy would be useful. The second breakthrough was the introduction of this so-called stent retriever called the Solitaire device, this first one. And they showed 61% of patients you could unblock the artery, whereas with the old one I just showed you, only 24% would. So a massive leap in effectiveness. And what it does, it pushes up again into the clot like this and expands into it and seems to grab it much more firmly, and you can pull it out, and the patient, if you get there in time, does quite well. But the question is, how well? And we knew there were lots of trials going on around the world. Steve and I started our trial. I'll show you in a minute. There was one going on in Holland that we knew about, and Steve and I were in Istanbul, where the World Congress was going on. I think, Steve, you were president at the time. And we said, well, here's another trial. We're 2,000 or 3,000 of us in the room. And we'd heard the rumour. No one knows the answer, of course. You'd hear a pin drop when these things are released. We thought, oh, it's going to be another one. Everyone was just of modest interest. It'll be pretty boring. But let me go through this. So they selected patients who definitely had a major occlusion of the artery. That was very important. The time window was about 6 hours after the onset. Initially, the recruitment was very, very modest. And Craig Drummond, the government said you are not to pay for any procedure unless they are in the trial. So people can't be reimbursed for any procedure outside the clinical trial. Suddenly, even though they were way behind us in recruitment, they rocketed ahead of schedule. They were ready before we were. And that's because governments can be more proactive in managing healthcare than they are at the moment. And that's a classical example. Positive result. Everyone, I couldn't believe it. In the middle of the presentation, the whole audience stood, and there was a standing ovation. Never seen it before, have we, Steve? Ever. Because everyone was so overwhelmed with the positivity of this result. So we also were running our trial at the same time. Because the result was positive, we had to stop ours because it wasn't ethical to continue. But we looked at our results and we selected our patients even more rigorously than they did. We had what we called a dual target, in that we had to have patients who had tissue on that scan that showed the tissue was still living, and also we had to demonstrate there was a very large artery block. So very, very carefully defined group of people who went into the trial, and then they're randomised to remove the clot or just standard thrombolytic therapy, clot dissolving therapy. And it also was spectacularly successful, and that's the second time we've heard a standing ovation. Was Bruce Campbell presented it for us, and people were equally impressed. So now this has been crunched with the other trials that all of us were doing around the world. This is our trial, our Australian trial. This is the Dutch trial. This is the Canadian trial. This is the American trial. This is the Spanish trial. This is the French trial. This is another American trial. So these trials, you can see, research it's a global business. We don't, if we're doing good for us here in Australia, we're doing good for everyone around the world, because they pick up the same result, and all these results confirm that this is indeed a very, very effective therapy. And this is the number needed to treat again, which just demonstrates that if you treat 3 people, 1 will benefit, and that's almost as good as penicillin. Penicillin is not 1-to-1, but it's probably pretty close to it. So this is one of the most powerful interventions in medicine in any sphere. And the effectiveness drops down a bit depending on how wide your criteria for what sort of people you bring into the trial. But ours was certainly the most powerful, merely because we selected the patients so carefully. So then other people said, well, you can do this out to about 6 hours. Why not go out to 24 hours? Because we demonstrated that brain tissue does live probably out to 48 hours on some occasions. And this is a bit complicated, but I just want you to look at here. Thrombectomy, which is the clot retrieval, 6 to 12 hours, so it's getting a pretty long window. Half got up and walked home. Half. Versus if you didn't do it, 20%. Only 20% get up and walk home. 12 to 24 hours, nearly half again get up and walk home. Whereas in this group, only 7% or so get up and walk home. So enormously effective if you demonstrate that the brain is still living as far out as 24 hours. So that is another spectacular advance that's occurred. So this just summarises where we are with this thrombectomy technique, which we're doing here in Melbourne. It's biologically extremely powerful. Its benefits are greater. I haven't shown you anything, but the bigger the vessel, the more spectacular the result. If we select people very carefully, you even get a better result. And we know that because of that time is brain effective is so important. Even if you go out to 24 hours, it doesn't mean that they won't get much more benefit the more quickly you do it. So if you could do it within a couple of seconds of the stroke occurring, the benefit would be 100%. But you can't, of course, do that. But we'll come to being able to do that shortly when Steve talks. And if you have to give a general anaesthetic, they don't do quite as well. That's another story. So this links with another thing which is going to link through to the stroke ambulance. So telemedicine. How do we get people to do exactly that? Get them to a form of treatment much more quickly, given that we know now that time is brain and every second counts. Well, telemedicine is one of the ways we can do that. This is the general principle, is that you've got a central laboratory, if you like, where someone is monitoring what's going on, or it can be mobile. We do it with a mobile device. You can do anywhere in the field. And you record what's happening with the patient here, and that message comes back to there, and we can also look at what the scan looks like, see whether it's a bleed or not a bleed, or the blockage, or where the blockage is, etc., etc. And this is one of our American friends in Houston, Texas, with his device in his ambulance there, which Steve will talk about. So this telemedicine program, which is federally funded with about $8 million, headed up by Chris Bladen and Dominic Cadillac at the Florey, have rolled out this to 16 centres all over Victoria. So they now all link in to this central system, and Chris has a team of now 16 neurologists, he was telling me yesterday, who are on call, and they do a session. They usually do a session for about 6 hours or so and respond to all the calls and make a decision about what should be done with that stroke patient. So we know that rural people are disadvantaged as far as their health is concerned generally, and stroke is no exception. The National Stroke Audit in 2009, Australia-wide, number of people getting clot-dissolving agents, 8%. In the country, only 2%. And this is so often with almost every intervention in medicine. And when they repeated the audit in 2015, still 8% Australia-wide, still 5%, or a bit better in regional Australia, about 5%. But after we'd introduced the VST program, this telemedicine program, it jumped up to 14%. And for those that are treated very early, 32%. So, and it's merely by improving processes. It's like flying an aeroplane. You just teach them to be process-driven so that it can do things extremely quickly. So not only that, they can do so-called door-to-needle time. That's the time once they get to the hospital, the time taken to start the treatment has gone down by 31 minutes. Now, 31 minutes is a massive amount of time in terms of potential stroke recovery when you're losing 2 million neurons per minute. So 30 minutes is a lot of neurons that you've saved, and that's by linking in with this telemedicine program where you've got someone, an expert on the end, telling them to do this, don't waste time, get on and do it, and giving them a protocol to do so. So this has been an extremely effective process. And it's just the beginning of lots of other things that are going to go on. And I'm not going to go on any longer, and I'm going to introduce my friend and colleague Stephen Davis, who's going to tell you something much more exciting than I've been telling you about, and that's the stroke ambulance. Thank you.
So I'm very excited to be working with Geoff and other colleagues who I'll mention at the end of this talk on the first mobile stroke unit in Australia, the Melbourne Mobile Stroke Unit, which I think really is the new frontier of stroke treatment. And I just want to emphasise what a collaborative partnership this is between the institutions, you can see here on the slide, and between many people, some of whom are in the audience. But without each of these partners, this project would not have been possible. And here is some of the team standing in front of the Mobile Stroke Unit. A lot of discussion of what we should call the Mobile Stroke Unit, but that's the sort of been agreed internationally is the terminology. MSU, often referred to colloquially as the stroke truck. But that's what it is. So and you'll see also them standing with their arms like this, arms folded, legs apart. This seems to be the standard paramedical approach that we've learned. Geoff and I copy, and we also have learned from the paramedics where the good coffee places are in Melbourne. Now, I think I pressed that one?
I'll have to advance it.
Thanks very much. So, here is the unit leaving the Royal Melbourne Hospital. Just to give you a sort of taste, it's quite exciting to go in the Mobile Stroke Unit with lights and sirens on. And some of the paramedics might be here in the audience, but they're incredible colleagues. Shane's here. Shane is here representing Ambulance Victoria. And Geoff and I have told this story many times before, but when we first pitched this idea to Tony Walker, who was then the interim head of Ambulance Victoria, he said, well, I just happen to have an ambulance out the back you can use. We didn't actually use that one, but AV has been a phenomenal partnership. So what is a mobile stroke unit? Well, it's a fully equipped ambulance with a CT scanner in it and specialised crew. So that's what ours looked like, and you're going to see some of the other units. And basically, the basic concept of the mobile stroke unit is because time is brain, we want to save time, that transportation time. So we move the hospital or the stroke unit to the patient. That's the basic concept. So we think, well, what do we actually need to treat a stroke patient in the field? Well, what we need is obviously a specialised team. We need a CT scanner because, as Geoff showed you, that revolution in the 1970s, Godfrey Hounsfield, of course, had the Nobel Prize for inventing the CT scanner in 1972, showed us what a stroke looked like on a brain scan, a CT scan, for the first time. So we can pick whether it is a blocked artery, an ischemic stroke, or a ruptured artery, a cerebral hemorrhage. And you need the drugs on board, and you need resuscitation equipment, and you need a team of people with special skills. So that's the basic concept. And here's just a simulation. This very sick-looking patient is actually a professor of nursing from Sydney. But just to show you what the inside of the ambulance looks like, and the team of people that would be working on the patient. And at the back there, and we'll show you a little bit more detail, is the CT scanner. So Jeff's talked a lot about time is brain, but let's just drill down on that, look at it in a little bit more detail. The whole concept of time of brain is basically, as Geoff showed you, that there's this salvageable brain tissue. We call it the ischemic penumbra. It's the area of brain that's not yet dead, but is at risk. And one of our colleagues, I might be able to show you hopefully on here. Don't know if I will. Maybe I'll show you on here. Is that showing the arrow there? We can actually measure this penumbra, as Geoff showed you, with MRI or CT, and it's a mismatch between the dead core in the brain and the tissue at risk. That's the penumbra. David Darby actually showed many years ago, one of a number of studies, that very early on nearly everyone's got a penumbra, but over time the number of people with penumbra drops off. So these were the sort of previous time windows for treatment: 4.5 hours for intravenous clot busting treatment. We used to say 6 hours for thrombectomy, but as Geoff's shown you, it in fact works out to 24 hours if you've got salvageable brain. So many people, but not all, have the penumbra going out to these very late time windows. So here's the curve for intravenous TPA. This is an unbelievably effective treatment, this intravenous clot busting treatment, and it's proven to work out to 4.5 or 5 hours. And with thrombectomy, we used to say 7.3 hours based on pooling all the information, but it probably, in fact, works longer. So it is a race. Every minute counts. Nearly 2 million neurons are lost in a typical stroke. So if you look at the workflow of how we normally treat stroke, you've got call 000, ambulance dispatch, extrication and transport, drive to the hospital, arrive in the emergency department, activate the code stroke, CT scan, and then TPA. This all takes time. And the basic idea of the stroke unit, of the mobile stroke unit, is you drag the time backwards. You push up those curves. Every minute counts, treat earlier, better outcomes. So Geoff talked about the number needed to treat. We are looking for the lowest number needed to treat possible, and ideally we'd treat a stroke within the first few minutes of onset. That's not possible, but we'd love to treat in what a surgeon called the golden hour, which is the first 60 minutes after stroke onset. So with stroke treatment, if you look at what happens in the real world, in the golden hour, the first 60 minutes, hardly anyone's treated. And in fact, virtually all of the information we've got about TPA is beyond 1 hour. It's possible, in fact, to achieve quite substantial numbers of patients within the first hour. This is data from Germany, from Silke Walter, who's collaborating with Geoff and myself, and they're able to treat 57% of patients within this golden hour, compared to control, that is patients arriving in the hospital, it's about 4%. Now, our preliminary data is not quite as good as that, but that's our aim, to treat people as early as possible and hopefully within this hour. Now, some of you have seen the Melbourne MSU outside. There are about 12 or 15 of these around the world, and they all look a bit different. So we've worked particularly closely with colleagues in Hamburg in southern Germany, and ours looks somewhat like their truck. This is the one in the Berlin, which is a massive lead-shielded vehicle that trundles around. They've now got 3 of these in Berlin. And here's some in the United States, and as you can see, probably as you get from central United States, west, and particularly as you'd imagine, in the central and southern United States, bigger is better. Bigger trucks, more Trump voters, bigger ambulances. Correlates with the size of the hands, or inversely with the size of the hands. So there's some very big trucks, and we went for a somewhat different model. So we went for a model where the MSU would kind of integrate into the ambulance service. We had a lot of discussions about this. Geoff and I, we didn't agonise too much actually, did we, Geoff? We thought we'd go with what was feasible and what would work. So we used a Mercedes-Benz 519. Mercedes is the standard ambulance in the fleet. It also helped that one of our anonymous donors is heavily involved with Mercedes, and that's the vehicle that we chose. Just to give you an idea of the world picture, this is where the stroke units are, and we've now, of course, implemented in Melbourne, and there are stroke units all over the world. There is one in Bangkok, the only other one in Asia. So currently we're staffed with 2 paramedics, one who's advanced life support, one is a MICA paramedic. We have a neurologist, we're planning to go to telemedicine. We have a nurse and radiographer. And just speaking personally, Geoff and I go out every 4 weeks for half a day. So we're not just sort of coordinating all of this, we're actually putting on our Navy uniforms and going out and being told by the nurses what to do. And it's very exciting. It's a real buzz and actually treating people. So this is the scanner. It's a fairly simple scanner. It's like a washing machine in the ambulance, but it can give you not only pictures of the brain, but also you get, so here's the brain here with the blood in it, the white blob, but we can also get pictures of the arteries in the brain called CTA. So again, this is the scanner, and show the stretcher there in the ambulance. And looking out to the back of the ambulance, this is Fran Langenberg, who's here today. She's the head CT radiographer, patting her baby there, the CT scanner. She won't let anyone else touch it, I can assure you. So how does all this work? Well, basically, there's an operational call to someone calls 000. They have a kind of algorithm that they go through where they ask certain questions. They decide it's a stroke. And then the model that we use is a co-dispatch model, that they dispatch the closest ambulance that would be appropriate for the job and the stroke ambulance. So we're both heading towards the scene, and if the first crew gets there and says it's a faint, or someone's with epilepsy's had a seizure, it's not actually a stroke, it's a stand down. They'll call us, we'll be going lights and sirens from Royal Melbourne, they'll stand us down. Otherwise we go to the scene. We assess the patient, we can image them if needed on board the vehicle, and then treat them on site. So we're treating outside the patient's home, saving that time, and as Geoff said, every minute 2 million neurons. So the funding we have is for a pilot. It doesn't cover all the strokes in Melbourne. We're operating within a 20-kilometre radius of the hospital. We deliver the patient to the closest appropriate hospital for either TPA or for and/or endovascular treatment, the thrombectomy. And this gives you an idea of the number of calls per day and our current radius. How many, if the trial, as we hope and expect, will be successful, and we'll also be obviously learning a lot from our overseas colleagues that we work with very closely. How many mobile stroke units will Melbourne need? Probably at least 3 or 4. At the moment we have 1 which is only operating part-time. Geoff talked about thrombectomy. Not only can we diagnose stroke, but the scanner allows us to diagnose the blocked arteries. You can see here the arrow. Get them into an appropriate hospital to pull the clot out and salvage brain. The other type of stroke that's less common, but even more dangerous, is ruptured blood vessels, cerebral hemorrhage. And just like with ischemic stroke, time is brain. And we can do a lot. We can lower blood pressure. If the patient's on warfarin or one of the other anticoagulants, we can use reversal agents. And in someone with a hemorrhage, Jeff and I are running a trial with Henry Zhao called Stop MSU, where we're using an agent called tranexamic acid, which basically stops bleeding. It's like putting a tourniquet in the bleeding blood vessel in the brain. So we're doing a trial within 2 hours of stroke on the ambulance. We've just started that and just treated 2 patients to date. Jeff mentioned telemedicine, which will be operating from the ambulance, and we're in pilot studies at the moment exploring telemedicine. So just to conclude, the MSU is very exciting. We have 6 to 10 calls per day. It's like a very busy stroke unit that's trundling around the city. We're treating with TPA. We're doing CT angiograms to triage for thrombectomy. We're reversing brain bleeds. It's a fantastic research platform for new drugs to treat stroke. And I think it really is a revolution in stroke care. But it's very dependent on the partners that I've shown you, which the Florey is one of the critical partners, together with Ambulance Victoria, who's here, the Royal Melbourne, the Stroke Foundation, the University, state and federal governments. And all of the people on here, some of whom are in the audience, are very, very important. So Jeff and I run it, but Henry Zhao, our clinical or medical coordinator, and Sky Clute, our nursing coordinator, Ambulance Victoria, critical. Damien Easton is a scientist who runs the Brain Centre at the Royal Melbourne and just done a phenomenal job, project coordination. Sharon McGowan from the Stroke Foundation has been an enthusiast from time zero, and we've got to find a way to get you into the MSU for one of the operations, one of the calls. Bruce Campbell, that Jeff mentioned with thrombectomy, very active in research. Bernard Yan. Fran is in the audience. And other very critical partners who are very much centred at the Florey. Chris Bladen, Telemedicine, and of course, ultimately the government wants to know just not how many patients we've treated and improved outcomes, they want to know it's cost effective. We did pitch to the Premier at the opening of the ambulance. We're thinking about an air ambulance, putting a CT scanner in a plane, first in the world. And he said, well, the professors can come to my next budget meeting. Thanks very much for your attention.